Hello and welcome to tonight's symposium entitled We've Got Your Back. My name is Rishi Gupta, and on behalf of the COS Working Group in Ergonomics and Injury Prevention, I'm very happy that you could join us for what will prove to be a very fun and interactive and entertaining and informative session. We're going to start with some disclosures. These are my disclosures, none of which are relevant to tonight's talk. These are the disclosures for Dr. Samuel Masket, the disclosures for Dr. Amy Zhang, and the disclosures for Mr. Randy Tressiter. A reminder that this is an event that is accredited for group learning activity as defined by the MOC of the Royal College and approved by the COS. You can claim a maximum of 1.25 hours, and these are the featured CanMed roles of medical expert, leader, and health advocate. Our learning objectives: to understand the impact that MSK disorders have on physician performance, job satisfaction, and workforce limitations. Recognize the ergonomic problems associated with workplace equipment such as operating microscopes, slit lamps, and indirect ophthalmoscopes, and appreciate what modalities exist to reduce the impact of MSK disorders and how this subject should be part of resident and fellow education. We are going to start with a polling question. So the question is, have you ever received any formal training in ergonomics? And I'm going to leave that open for a couple of seconds. Okay, and we are seeing that 65% on the call have not received any formal training in ergonomics, and we are hoping to change that. Just want to talk briefly about the working group. It was established in 2024. We look to try and bring in experts from across the country with varying heights and gender, practice setting, stage of career, background, and practice focus. Our vision is to educate every Canadian ophthalmologist on ergonomics and injury prevention and how to mitigate risks. Our mission is to eliminate work-related injuries for Canadian ophthalmologists, and our values are of respect, passion, teamwork, creativity, inclusion, and diversity. This is the group. We have 12 attending physicians. We have 3 resident doctors to give the trainee perspective, and we have 2 non-physicians. I want to give a big thanks to the Scientific Planning Committee, to Drs. Devin Betch, Jamie Bamra, Patrick Gouy, Rukeya Mather, and in an advisory role, Cynthia Lank, our project manager and medical writer, Dr. Ojas Srivastava, who gave the resident perspective, and Randy Tressiter, who is our injury prevention consultant. And before, again, we get started, a huge thanks to our COF staff. Without them, we would not be able to be doing any of the work that we are doing. We're very lucky, I think, to have the strong leadership that we do. I want to talk to you briefly about the goals that we have. We have a whole host of different projects, including this annual COS webinar that you are attending. We are looking at various COS members and highlighting their ergonomic journey, their ergonomic stories. We are working towards creating an ergonomics handbook, an ergonomics curriculum. We want to send out little blurbs through the sightlines, web blasts, as well as some social media challenges, posting some resources to the Practice Resource Center, and we are looking to have a presence at the COS annual meeting with our annual course. Tonight, of course, we are at the webinar, and we will also be premiering the world premiere of our Year 1 My Story video. One more polling question before we move on. We want to know, does your practice setting have a culture of ergonomic safety? And we will leave that up for a couple of seconds. Okay, so about 56% feel that there is not a culture of ergonomic safety, and maybe a fifth are unsure. Okay, so I'm very excited to present our year one video. This features Dr. Dan O'Brien, who is a mentor of mine, a colleague here in Halifax, and a big thanks to Dan for taking the time to share his story. So we're going to play that video right now.
Ophthalmology is a fantastic specialty. We deal with patients who are blind or visually impaired, and with the technology we have these days, we can help people regain their vision so that they can become productive, so that they can have some quality of life associated with their vision. I'm Dan O'Brien. I've been doing ophthalmology for 40 years, and it's a rigorous specialty, spending a lot of time in the operating room. As a consequence of that, at about 10 years into my practice, started to create some problems. There were times where my neck was so sore, I felt that the lactic acid was building up in my neck, and I thought, well, this is just another form of exercise. To sit without movement for a significant period of time, that could cause some long-term issues associated with your own body. I thought that because of my physical fitness, I'd be able to power through a lot of these difficult positions. And early on in my career, I was able to do that. But later in my career, it came back to create some issues and some problems. And I had two significant musculoskeletal issues. Throughout my career, it probably recurred maybe 8 to 10 times or so. And each time it was there, it lasted probably 2 to 3 weeks before I was able to resolve it. And I was able to resolve it 100%. I felt really, really good. However, at one point, it didn't resolve and it didn't start to get better. And at the same time, something else changed a little bit. I started getting a little bit of tingling in my arm, and I thought, oh, that's curious. So I ended up actually seeing a neurosurgeon. I had some imaging done, and it became evident that I had some narrowing at my C5, C6 disc space, and I had a small osteophyte there impinging on my nerve, and that was causing the taser-like feeling that was going down my arm. I was starting to wonder, is this going to be something that's going to create a problem with my longevity in my career? But in addition to that, once I decided that I was going to go and have surgery, there are a lot of issues associated with that. I had never really taken much time off work before, so that would be a significant change. I also thought that if I took time off work, would I ever get back to work? And that was worrisome for me. I felt like I was still relatively young to develop a musculoskeletal problem, but things can happen to young ophthalmologists, even early in their career as well. We all know that care of the patient is critically important, but care of yourself also is important. You really can't look after a patient if you're unwell or physically unfit or suffering from an injury. If I had some advice to give young ophthalmologists, I would say stay fit, care for your patients, but also care for yourself. Learn about ergonomics and incorporate it into your practice. When we're young, we all feel invincible.
Wow, that was an amazing video. Thank you so much, Dr. O'Brien, for graciously taking the time from your busy schedule to help create this powerful video. This will certainly help raise awareness around ergonomics and injury prevention. That was truly amazing. Thank you. All right, without any further ado, I'd love to introduce our invited speakers. Dr. Samuel Masket is clinical professor of ophthalmology at the Geffen School of Medicine at UCLA and founding partner of Advanced Vision Care in Los Angeles. He has served on the board of trustees of the AAO and is past president of the American Society of Cataract Refractive Surgery. He's published over 150 peer-reviewed articles and 2 textbooks. He serves on the editorial board of AJO and several other medical journals, and is the consultation section editor emeritus of the Journal of Cataract and Refractive Surgery. He has been an invited guest surgeon and given numerous named lectures globally, including the 1998 Binghorst Medal Lecture and the 2013 Kelman Memorial Lecture at the AAO annual meeting. In 2013, Dr. Masket embarked on a new venture, establishing the Samuel and Barbara Masket Foundation. Its missions are to provide anterior segment eye surgical care for the underserved to train fellows and support clinical research. So welcome, Dr. Masket, and thank you so much for accepting our invitation.
Well, I'm happy to be here, and I think this subject is of great importance, so I really like to spread the word, so happy to be here.
Wonderful, thank you. As well, we are very lucky to have with us Dr. Amy Zhang. Dr. Zhang is an associate clinical professor of the glaucoma service at the University of Michigan Kellogg Eye Center. She was previously at Case Western University, where she was the glaucoma fellowship director. Her clinical interests are her work in patient education and home tonometry. She has been part of the patient engagement subcommittee with the American Glaucoma Society and one of the co-founders of the Glaucoma Chats in conjunction with Bright Focus Foundation. Most recently, she was selected and finished the American Glaucoma Society Health Policy Leadership Development Program. She is the Well-Being Director for the Department of Ophthalmology and most recently a faculty associate of the Office of Well-Being at Michigan Medicine. She has an interest in improving ophthalmic ergonomics and looking into addressing drivers of burnout across the health system. She has collaborated with the School of Kinesiology and has current collaborations with industrial engineering, examining the role of human factors engineering in healthcare. So I'm just going to unshare my screen here. And Drs. Masket and Zhang, thank you so much for being with us, and the floor is yours.
Great. Dr. Gupta, thank you once again for this invitation to speak. As Dr. O'Brien's story highlighted, the sort of importance and education and importance of awareness regarding ergonomics or musculoskeletal injuries within ophthalmology. Dr. Masket and I are so excited to have a conversational dialogue about this topic that is very near and dear to our hearts. And we have a viral MRI to start off that discussion. Dr. Masket, I will turn over the floor as this MRI definitely has your name on it.
Well, I like to consider myself an influencer because this photograph, the one on the left, actually appeared on I believe it was the August 2022 issue of iNet. And I was very, very pleased that they brought this subject to light. Until one suffers from a problem, a work-related problem, a musculoskeletal problem, I don't think they're really fully aware of how these things happen, why they happen, and perhaps what can be done to prevent and or ameliorate them. So obviously you can see I have a couple of areas of stenosis in my neck, and I also have an increased lordotic curve to my neck. If you compare it to the normal younger individual on the right, who is clearly not an ophthalmologist. But my entry into this arena was because of my own issues. And just as you heard from Dr. O'Brien about having pain and then tingling in his upper extremities, I shared the same experience. However, it was near the end of my career, and it turns out that working less alleviated my problems. So to date, I've not required surgery. Back to you, Amy.
Okay, so good to hear that it happened later on. I think for my own experience, even as a resident, I was starting to have some numbness and tingling, perhaps because of my shorter stature. I sort of encountered these difficulties and sought out mentors, surgical mentors, clinical mentors to ask advice as to how or if they experience something similar. And most of the responses were definitely caring, but sort of lack of education, lack of awareness, and really not a solution finding. So some of the advice I was given was, as you continue on, perhaps you'll get better at the examination and you won't be in such awkward postures. So I would love to hear, Dr. Masket, when you were going through training, if there was someone to guide you, whether you yourself educated yourself regarding this topic.
Sadly, not at all. It was interesting to see the responses in the panel or the questions sent to the participants. 65% had no ergonomic training whatsoever in their program. And clearly, the attention needs to be paid to the trainees. There are many, many long-term consequences, not just to the individual's health, but to our workforce as well. If you review the literature, somewhere 12 to 14% of ophthalmologists retire prematurely just due to MSKs. Now, MSKs also play into the burnout and the wellness issue. It's just part of the equation. But we have at least here below the what is the 54th parallel? We have a situation in the U.S. where we have a very much an aging society. So we have more older people who require ophthalmic care with respect to cataract, glaucoma, and macular disease. But we are not producing more ophthalmologists. Unfortunately, we graduate just about 450 per year, and we're retiring about that rate or perhaps even a little bit faster. So we are really looking at a potential workforce problem just due to the demographics alone. So keeping people able to work longer is really important. Now, you mentioned training. One thing that was really very surprising to me, as an employee of the American Academy of Ophthalmology, if you just go to work there in some secretarial or technical capacity, whatever it is, in their main office in San Francisco, within 1 week of your arrival, you will have an ergonomic assessment of your workplace, et cetera, and how you work with the tools at your desk. Now, as we can see from the respondents today, the minority, the very minimal amount of training has gone into ophthalmologists. So here, the Academy, and I don't know about your Royal College, but the Academy really isn't training ophthalmologists, but is paying attention to their workforce. So we need really to address this at a young age, because by the time you reach, a long career, if you have a lot of physical disabilities, as you can see in my MRI, those are not reversible, but they are to a great extent preventable. So we have to learn how to work with the instruments. We need people to supervise us. And we also need to work with physical therapists, ergonomists, and what have you, so that we nip this problem in the bud rather than have it build up and create problems for us. So in my training, it was all about the patient. Everything was about making the patient comfortable. And there also was this culture of the more you work, the more you learn, which is true perhaps in training, but also maybe the better doctor you are, the better person you are. Throw in a little bit of testosterone, then you've got some ego thrown into there. And it's always about the patient and working and how many cases you did and what have you, rather than what was the impact on your body. And this is not new, and it's really time for it to go away. Now, fortunately, we have caught the attention of the AUPO, the Association for University Professors in Ophthalmology here in the States. And so we see the light at the end of the tunnel, and programs such as this, raising awareness, is the most important part to me in solving a problem. First, recognizing its existence. And I want to thank you for bringing this to the attention of Canadian ophthalmologists.
Yeah, to add to some of the points that you've already brought up, I think at least I see with our residents, this generation is certainly a lot more vocal about what their interests are and about what issues that they see. And I think it is really important to then give them a skill set or tools that if they're interested in learning about ergonomics, that we have the tools or the curriculum sort of up in place to educate them instead of saying, well, yeah, that sounds like an important topic. You should go figure it out. So I do think just like as we guide them through aspects of surgery, we should also do that both in the clinic as well as the surgical setting. And Dr. Masket. I think you and I had talked about this a lot. There's a lot of emphasis on the surgery side, but when we look at our professions as ophthalmologists, we do spend a fair amount at the slit lamp in the clinic. So I wanted to hear your perspective on that as well.
Well, let me go over a few things on that subject. Firstly, when Dr. Gupta introduced me, he mentioned about this fellowship program that we have. And within the first week or so of our fellows' first experience in the OR, I take videos and still photos of how they sit, what their posture is in the OR, so that I can discuss it with them. And interestingly, the young people that we see they have far better ergonomics than I did. In fact, there was a time where ergonomics to me in the OR and what I used to teach was that it's about how you position the patient, not how you position the surgeon. And you position the patient to create the best exposure and the best comfort for the patient. If the patient is comfortable, the chances are the surgeon will be comfortable. But it's more important that the surgeon pay attention to his or her comfort as well as the comfort of the patient, the exposure of the eye, etc. Amy, you raised this subject before, and we're going to go now to the slit lamp and what have you, that you seem to have a problem at a younger age, perhaps because of your height or what have you. In fact, if again, looking at the literature, looking at the data, unfortunately, women, there's a higher incidence of MSKs in women than in men in ophthalmology, perhaps because of body habitus or what have you. The other thing, when you look at the examining equipment, slit lamps, as an example, those oculars don't incline. One of the manufacturers, Hogstrite, does have an optional at an extra expense, and not inexpensive, binoculars or oculars that you can change that are inclined 20 degrees, but also not variable. If you take a look at the way the usual office setup is with the slit lamp and the chair and the footrest for the patient, I mean, these are mostly designed for about 6'4" Swedes who weigh 130 pounds and ophthalmologists who are built pretty much the same. Ergonomists were not involved in the design of these instruments. And in fact, I think my neck, I know that near the end of my very active clinical practice, I was more tired at the end of an office day at the slit lamp than in the OR, because in the OR, you can adjust many things. You can adjust your seat height, you can adjust the pedals, you can adjust the inclination of the oculars and so many other things. But the slit lamp is a killer as far as I'm concerned. It used to pain me just to look up and then go back to look at the patient. It's difficult to position the patient at the slit lamp, particularly, at least the patients in my practice were not built like those Swedes. They were often short, somewhat rotund, and getting them to have their head at the plastic and their chin in the rest was often a challenge. And so we, as the examiners, tended to reach more to the patient than have the patient come up to us. Now, people have modified the slit lamp tables so that we can be closer. And I think the examining chairs are also hugely problematic, particularly with respect to the footrests. I almost invariably had to lift the footrest and let the patients dangle their feet so I could get more comfortable. So, it's not just the slit lamps, the indirect ophthalmoscope. You realize the contortions that we put our body through. Now, in my training, and I'll give credit to the retina people who trained me, we examined retina patients recumbent on an examining table. So it was a little bit less rigorous on our necks and backs than we do it in the examining chair. Examining chair is murder. You're distorting your neck, distorting your back, distorting your wrists. I imagine the retina people suffer even more than we do, but they maybe take the time to properly position the patient. So even though people talk about the OR as being problematic, I think the examining room, also, if you add into it, trying to put notes on the electronic health records and constantly turning, that's also murder on one's back and neck. So it's tough. It's tough what we do, but however, we're going forward, and we're going to talk today about moderating what we do, taking time to rest, stretching, and all of those things to make life a little bit better. But again, awareness is the whole key.
Yeah, I think that is so important. And what you touched upon, even within subspecialties within ophthalmology, there may be some other ergonomic challenges. For example, pediatrics and maybe oculoplastics do have the use of the loops. And so I think that also adds a different layer. So I think within each subspecialty, there may be some pertinent pearls. I'm sure Dr. Gupta has some insights regarding retina, but even in terms of room layout, right? If we think about how we position the monitors, the office things that we're now having to use, back then when electronic health system and medical records were not a thing, perhaps you could pivot more towards the patient, sort of jot down your notes on paper. But now we have a computer that maybe just a desktop and sort of more limited. I was curious to, as the years evolved, what has your experience been with your layout for your specific offices?
Well, to be really honest with you, I always worked with a scribe when we
Ah,
had, handwritten charts, and then when we moved to EHR. Um, it wasn't for the ergonomics, although that's probably saved me a few years. Um, is really so I could relate and explain to the patients and let somebody else handle that. It's a more efficient way to practice. Um, it enables you to see more patients, and so the cost is not a factor. So I believe very, very firmly. In fact, I work with two scribes, and I think that's the way to go, not just from an ergonomic standpoint, but hugely important. Um, to better communicate with the patient, and it's better use of your own time. I know people think it's cost effective to write their own charts, but we carefully analyze that, and I don't agree with that at all.
yeah, that's great. So the solution, everyone, is we
Hmm.
must each have two scribes. I think that's my biggest takeaway so far. No, um, I think the other points are so relevant. I think thinking about cost and time, right? But the cost in terms of investing in ourselves. I think another thing that we talked about was when we think about professional athletes, right? And sort of the support and system around that. And Dr. Masket, I love your analogy. I know you gave me one, but I forgot the sports player because I'm not very good with sports that you were highlighting. And I think you can tell the story a lot better than I can. So I'll give the floor to you for that.
Well, it has been reported. I can't vouch for it, but it's been reported that LeBron James, a basketball player, he's the highest scoring player in the history of the NBA, and he would be placed maybe at the top. I don't know. I mean, people argue who's the best and what have you. But nevertheless, it's alleged that he spends $1 million a year on physical conditioning. Um, Also, if you're interested more in tennis than in basketball, if you look at Novak Djokovic, who's now 38 years old and still competitive, he's considered, I would say, the third best player in the world today. And right now in China, the Shanghai Masters is going on. The weather is brutal. Younger people are dropping out like they're dropping dead like flies. But Djokovic is he's in the semifinals, and he has an extensive physical conditioning program, involves diet and what have you. So these athletes These elite athletes invest hugely, both in time, money, and in many other ways, meditation, physical training, on and on, in their bodies. Well, we are not high-paid athletes, all right? We're not even high-paid anything anymore, but we are peace workers. And so I don't really like the term "you eat what you kill," but by and large, if you need to see a certain amount of patients to balance the books, and you really should be investing in your physical health, and through again includes diet, exercise, activity, etc., so that you can perform at your peak. It's not easy being us.
Yeah, something that I learned from Dr. Gupta actually, the amount of force that you're exerting on your lumbar discs is a lot more when you're sitting than when you're standing. And I think that sort of suggests when people have back pain, oftentimes it's easier for them to stand rather than sit for long periods. And when you're sitting, it actually engages your core a lot more. So you have to have a very robust core stability. I know all of us have 8-point abs as part of our entry into ophthalmology. And I think we just need to find a way to preserve that throughout our careers. So I think until we have that $1 million budget for our health coaches and stuff, we really need to think of other creative, more cost effective ways in which we can sort of share that information. And as physicians, we should be a promoter of healthier lifestyles. But specifically for surgeons, I think that do a lot of sitting, it is incredibly important to focus on exercises that sort of master your core. And it may not be restricted to certain styles, right? I think both Dr. Masket and I were talking about Pilates or yoga or strength training. I think the wheelhouse is out there, but sort of focusing on the core work groups of where you need to have that stability is really important. Um, Dr. Masket, I think you alluded to some of this already, but within ophthalmology, there are so many new innovations that are coming out with newer technologies. Where do you see that role of working with industry or working with our partners in terms of ergonomics?
Yeah. Well, I think it's hugely important that we let the manufacturers know what our needs are. You can see some of the ads now are paying attention to this issue. So I think it's really important. I mean, you have to engage not just educators, but you have to engage ergonomic specialists and the manufacturers as well. So one of the things that's been developed over recent years is what's called heads-up surgery. That is where instead of looking through the oculars of a microscope, you're looking at a screen directly in front of you and projected in 3 dimensions. So your head and neck are free to move as you will, rather than being plastered, so to speak, up against the microscope. And to a great extent, this can be very, very much helpful. It isn't perfect though, because the microscope is there and you have to kind of look around the microscope to see the screen. One of our colleagues here in Los Angeles, Arjan Hura, when he was in training at the University of Cincinnati, worked with one of their retina people and actually did EMG studies, all right, comparing what muscles are stressed during standard microscope surgery, and that was in a vitreoretinal surgeon, versus heads up. And there was a significant difference, much less stress working with the heads up. Problem with the heads up, though, is besides having to look around and not being able to look straight ahead, is that for an assistant, then that sometimes creates issues of torting or torquing their neck. There's another device now that's in development, and I think it's commercially available, where the surgeon wears a headset with a virtual reality So there's a microscope, but instead of looking at a remote screen, the surgeon is just looking in the headset and seeing the image of the eye. There's also a lot of other information in that headset that is available to the surgeon. We've worked a little bit with that, and there's some color issues. It's not perfect yet, and one of the problems with it is that it's not fully remote. It's tethered by a cord to the microscope, and that creates a little bit of a weight on the head. But these are technologies that are new. So both Zeiss and Alcon have the heads up, and I forget the company who makes the headset. But we're very early. We're 5 years in, roughly. I mean, so given time, I'm sure these technologies will have even a greater application, greater advantages, and will help us quite a bit. One of the other things that will probably help a lot in the office, I'm told, and I don't know that it's true or when it's going to happen, but I'm told that in the foreseeable future, the slit lamp will be obsolete, that it's all going to be done by OCT imaging, so we can look on a screen rather than be again married to the microscope, to the slit lamp microscope. So I can't speak for indirect ophthalmoscopy, but I'm sure that imaging is coming there as well. So these things will take place, I'm sure, within the next decade, and maybe they will be career saving or career prolonging. I expect that they will be. So there's a lot that the manufacturing sector can and should do to work with us and help us along those lines.
Yeah, that's so great. I think when we think back in terms of technology, right? When Apple sort of introduced their Apple Vision, there were a lot of complaints from customers that sort of returned the device because of the weight. And I think as we're designing these portable technologies, we should look into the commercial side and see these problems are not unique to these devices that they're sort of tweaking for ophthalmology, and sort of learn from that experience as to how to best serve the physicians who be using this. So I think it's certainly very, very innovative, and I think we need that. And it's also sort of other things that we've heard on the commercial side that perhaps we can learn from those earlier issues to further improve the product. Um, and so, but I agree. I'm super excited about the innovations that are out there, and perhaps for those of us who are still using the slit lamp, eventually it will be replaced. But I think the cost of newer technologies and sort of the implementation of that is something that we still have to prepare for, because even though the technology may be available, there may not be every single clinic that have the resources to be in the newest technology. So I think for many, the slit lamp may still be an issue for time to come. And as we continue to train our trainees, I think the skill sets of protecting their bodies is still very essential.
Yeah, before you move on to the next subject, I
Sure.
think it is incumbent upon the COS and the AAO to be putting groups together that would include the manufacturing sector, physical therapists, clinicians, and ergonomists. I think I think that's where the responsibility lies. In terms of the Royal College and the AUPO, they need to guide the training programs to incorporate it. But I think in terms of how to get all of the stakeholders together, I think then our national organizations need to really take charge of that.
Yeah, I definitely echo that. I think if we look at history and we look at dental hygienists, when they sort of unionized and kind of worked to bring up this issue of all the increase in musculoskeletal injuries, that's where they really sort of revamped their workforce and thought of ways to adapt and also having technologies that adapt. But I completely agree that we need to get all the stakeholders together to have a very robust discussion, and not just a discussion, but an action plan to carry forward this mission. Um, I was curious to get your perspective on what you hear from other fellow surgeons in terms of relatability of incorporating ergonomics, or what do they say about certain pearls they may have relayed to the younger population?
Well, it's really interesting. Um, People don't often talk about it, but if you raise the subject, people will tell you about their aching back and their aching neck. I know I would say it's my neck that limited my career, although it was probably, I was probably getting close to where I didn't belong there anyway, although I'm not sure of that. But my back also was problematic. And so Pilates really, really helped me a lot. And when you start, you're in the OR and maybe in the break room, you're in between cases. We have a surgery center with 6 rooms, so we have a lot of colleagues that we see all the time. And it's funny, once you mention it, a lot of people will tell you the problems that they're having and maybe how they've dealt with it. And as in your case, it's not just my elderly group, but I don't think anybody in my age group has gotten away scot-free. I mean, there's no question that all of us are impacted. But there's an unfortunate situation in medicine. I mentioned before testosterone and toughness. Physicians don't like to show that there's anything wrong with them. They want their patients to think that they are, perfect specimens. They don't want to admit to a weakness, because it does raise the concern that they're maybe not able to take care of them. So this machoism, has many prongs to it. And again, one of them is not admitting our problems. Um, and I think, again, as I said before, if you recognize a problem, you can approach it. If you don't recognize and admit to a problem, then unfortunately, there's nothing you can do. It's all denial. But this machoism it's really a problem um, with physicians. We're afraid. For example, many physicians are burned out. They don't want to admit that they're going through burnout because they think it may impact their hospital privileges, or again, how their patients view them. Um, I hate to keep getting personal, but a number of years ago, I developed very, very large bags under my eyes. It was a familial trend. They came on within a year. And my patients would say to me, "Boy, you look tired. Boy, you look tired." And well, I was mostly tired all the time, but nevertheless, I mean, even when I wasn't, they were telling me that. So I felt, because I was getting older, and this is the appearance that patients took from me, and this is the sense they had of me, I had my lower lids fixed so that I would not have the appearance of someone who was incapable or elderly or what have you. So, I mean, I don't think I would have been concerned so much with the cosmesis had it not been for how patients viewed me. So we as a group, I would say to the office when we started our day, it's showtime. No one has any problems, right? No one has any of this. It's all about the patient. And, we do want the patients to have a very positive experience, not just the care we give them, but what it's like to be in the office. But that really, it tends to translate to, we don't like to, show our dirty laundry and talk about our own physical or mental problems.
Yeah, that's so great to kind of humanize the experience and say that, we're not above these other
Mm.
traits that affect all other humans, because we are humans at face. And so I think in the last couple of minutes, as we're concluding our conversation, I would be really interested in hearing about maybe 1 to 2 pearls about how you handle certain ergonomic setups, or what do you incorporate into your clinic or surgeries?
Well, I wasn't very good in the clinic. I mean, but we did have, I even learned how to say in a variety of languages how a patient should separate their legs so I can lift the footrest so they could get closer. And I learned how to say it in Russian, right? And when I was going to Russia, someone said, don't say that on the streets of St. Petersburg. Called "Раскройте ноги, пожалуйста." It means separate your legs, please. So, so that's that, and making sure the patient sat closer was the only thing I really did in the office. But in the OR, I did something that most people don't do. I don't think they take the time to set the patient and myself at the scope. So rather than just going in scrub with the patient draped, patient be brought in the room, I would sit for a minute and position the scope, position their head, and position my body. And that extra minute or two was so worthwhile because, again, if the patient's comfortable, they'll cooperate. And I mean, all of us have experienced what it's like to deal with patients who have, significant kyphoscoliosis, and you've got to position them funny. But if you spend the time to do it at the outset of surgery rather than, after they're prepped and draped, it's really going to make life much easier. So I always felt that that extra minute or two to set the patient before were prepped and draped, I thought that was really, really worthwhile. So that's probably the biggest pearl, I would say. So that's like I said, ergonomics is everything, but it's there. It's both how the patient is positioned and how the surgeon is positioned.
Yeah, I think my 3 pearls are that sort of incorporating the P's is how I like to think about it. So, number one, the first P is sort of picture your form. And to Dr. Masket's saying, where he would actually take photos or videos, you can't fix your posture unless you actually know what your posture looks like. The second P is know your presets, meaning know how high the chair needs to go during your exam. Also for the OR, hopefully your upper torso height doesn't fluctuate too much. So I think knowing the presets of where you're comfortable sitting at both the slit lamp as well as the surgery draping area is very important. And then finally, practicing your micro breaks. I think taking smaller breaks throughout would also be something that reminds us to sort of reset our posture. And I think in our next session, or in coming up, we're actually going to specifically talk about that. But I think the 3 Ps, so picture your form, know your presets, and practice taking micro breaks are what I would want to give to our audience in terms of practical pearls that you can do even tomorrow in clinic or in the OR.
That is amazing. Thank you so much to you both. What a wonderful conversation. I picked up a lot of things and really enjoyed hearing the interaction. Really, really appreciate it. We are, as you alluded to, Dr. Zhang, we are going to be doing a little micro break in a second. I'm just checking here. Can you see my screen being shared? Amy, do you see my screen being shared? Thumbs up. Okay, great. So I am going to introduce Randy Tresitter. Randy was huge in my recovery. I had a lot of back pain 5 years ago. Randy came into the OR, watched my movements, and gave some really good recommendations. One thing he told me was, you are freezing and that joints like movement. So Randy, I'm going to pass the mic over to you just to introduce yourself and the importance of these micro breaks. Maybe you can highlight for us, and then we'll No ergonomics webinar would be complete without everybody moving. So please feel free at this stage. We've been sitting for a while to get up and shift yourself, to all the audience. So Randy, the mic's yours.
Thank you, Dr. Gupta. So my name is Randy Tresitter, and I'm an injury prevention consultant. And I was asked by Dr. Gupta to come into the ophthalmology OR to look at the ergonomics of the staff and surgeons during surgery. Two things that I noted were non-neutral postures that were being maintained in a static position and taking the time to ensure a good setup prior to starting procedures with each case. Now, Dr. Masket did talk about changing the setup between patients and making sure that you are set up, take that minute or two to do so. But now I want to talk further about micro breaks. So a saying that I heard in the past and I propagate is the best posture is your next posture. In other words, you want to move to encourage blood flow and providing nutrition to your spine. All joints love movement. And so working with Dr. Gupta, we came up with the following exercises to provide a 20-second break that can be done every 20 minutes. You can use this or create your own routine. The key is to take breaks and move your body.
All right, so let's take a look at our 20-second micro break during a surgical procedure. So some movements we want to try first are a little bit of neck retraction. And if you feel up to it, add a little bit of head back. Then look at shoulder shrugs. Or if you prefer, rolling of shoulders. Either one is fine, getting the blood flow. Then we want to take a look at our wrists and move them. You can move them either direction to do a little bit of a stretch, hold it at the end, move your fingers, get the blood flowing. Then we want to take a look at leaning back. And then finally, we want to do some weight shifting to be able to get the blood flowing in our hips and our legs. Pick your feet up if necessary. All right, are we ready to time this? So there should be a little timer on the bottom of the screen. And now 20 seconds.
Okay, that's great. So I think as Randy said, you don't have to do those specific movements. I have found this to be really helpful in the OR. Sometimes it's hard to remember to make that shift after 20 minutes. It also depends, of course, if you have a cataract list, for example, or if you're doing longer cases. I tend to do it if I'm doing combined vitrectomy and cataract cases after the cataract is done. So I just remind myself that's the time point I'm going to get up. I'm going to, take those 20 seconds just to move and reset. So please do think about doing those micro breaks. We are moving on to our Q&A session. And I think we do have already some questions being posted in the Q&A feature of Zoom. Please do send more questions in. So I'm going to put to our panel our first question, which is talking about being at the side scope. So this question is near and dear to my heart because when you spend a significant period of time doing a vitreoretinal fellowship at the side scope, you get to see how bad that can be for your neck. So I've been there a significant period of time. The question is essentially, can you talk about injuries due to teaching scopes on microscopes? As teachers, we sit uncomfortably, incorrectly, and I feel this is also a significant cause of injury in the OR, especially with long cases. What are the solutions to that?
Well, yeah, there are side scopes and there are side scopes. There are some that are not adjustable. There are some that are not 3D. There are some that have very poor lighting, and I consider those completely worthless. And so we have, as I mentioned, we have 6 ORs. And in some of our ORs, particularly the ones with the Zeiss Model 700, we have assistant scopes that are as adjustable as the surgeon scope, and they can be focused separate from the surgeon scope, and I don't fatigue with those. So, but they're obviously more costly, and I don't know if they're available for the earlier generations of the Zeiss scopes, and I don't know about competing products, whether Leica or the other manufacturers have very comfortable scopes for the assistant. But I know that I refuse to go into a room because I no longer am the primary surgeon. I just assist our fellow when necessary. But I will not allow the side scope to be an inadequate scope, because I can't be of any value. And it's murder, absolutely murder on one's neck. It's worse being the assistant with a scope of that nature than it is being the surgeon. So I think we need to put our foot down, and we need to have those type of side scopes that are adjustable, et cetera, et cetera. Then the question comes up about whether we should be working remotely. Again, if the problem is, you need to have a pretty straight-on view of the screen in order for the 3D glasses to work. But I think that would surely be helpful. Like anything else, there's a learning curve. And so, perhaps Alcon or Zeiss would bring those units in, and let you try them in your OR. And again, you're not going to notice a change perhaps in 1 or 2 cases, but after a few, because any new piece of equipment does have, a period of learning and adjustment. And the curve, I don't think, is very steep, but we need to take advantage of technology that works. Old attitudes and old equipment are what's killing us.
Yeah, I would echo that. I think the other part we need to highlight, especially if let's say it's the trainee that's at the side scope, is that they need to somewhat modify their positioning to make sure that they're comfortable as well. And we need to be lenient of the time that it might take them to get a little comfortable. So I think oftentimes when we switch, we sort of just we pick right up and we start right away, but we need to take that extra time to make sure that, perhaps that they're sitting comfortably before we resume, right? And I think taking those extra few seconds for everyone to get more comfortable, and certainly with the more adjustable scopes, it would be easier to do so. But even mild modifications to how they're positioned in terms of their chair, like getting the chair a little bit closer to the bed, could make a big difference. But taking that time to do so and knowing that that's okay is very important.
Those are great answers. Thank you very much. We have another question in the Q&A. Do you have any thoughts on hanging from a bar? So a dead hang, essentially. Any benefit to that? Any specific exercises at the gym you would recommend? Before I toss that to the panel, I'll just say that I actually got a personal trainer not too long ago, and I brought that person into the OR, into the clinic, to show them everything I'm doing. And I said, fix me, help me. So I would highly recommend thinking about that. But Doctors Masket and Zhang, do you have any comments about specifically the dead hang or any specific exercise that you would recommend?
I don't know that much about the dead hang, but recently I have been more doing sort of weight training, so sort of strength training in general. And I think building up certain muscle groups, especially to facilitate what we do, such as the upper body, the core, are very important target groups. I don't have any super specific exercises. One that I think is really good for everyone's core, if your knee can tolerate it, is something called the bird dog, where you are sort of I'm bad at I will not be able to illustrate what bird dog looks like, but essentially your opposite leg and arm should be raised with your back fairly straight. I'm sure you can look up a much more informative video than what I'm trying to articulate. But I do find that to be a really good core sort of awareness as well as strengthening. I'm sure Randy has some great suggestions. We should actually talk to the expert about that.
Absolutely.
So I'm gonna say that when I was reviewing the literature on what exercises are appropriate, etc., that there was a lot of opinions, but there was no follow-up. So in other words, if somebody did a study on these are the best exercises, they wound up later on, they never checked, like did the 6 month or the year-long study to, or even 5 years out to figure out were these effective, were they not? That's why I tried to break it down to micro breaks. Do something that you're going to do. So if you don't want to dead hang, I wouldn't dead hang. Um, Plus the fact that I'm kind of thinking that if you're doing a dead hang, what's it stretching? Is it causing other problems? But I prefer, like Dr. Zhang, your approach where you're looking at the muscles to try and tone yourself, to try and build up certain musculature, to try and get yourself better into a habit of doing that, rather than paying attention to specific exercises. In other words, get moving and keep your fitness.
Great comments. Thank you. We have a raised hand, and that is, I apologize if I'm not pronouncing it correctly, but Julie Morin. So we'll unmute Julie, please. Are you there, Julie? We'll maybe move forward to the next question. And that is, do you recommend using slit lamps with attachments like the Hogstrite stereo variable or a camera attachment which extends the length of the slit lamp so you don't need to lean as far forward? Is anybody familiar with these attachments on the Hogstrite?
Yeah, we have a slit lamp, a camera that, yeah, that does make it easier to get there. But then there's some other issues about working around the camera, what have you. So it's not all good. I never had the opportunity to try the 20-degree inclined oculars. I'd rather see something that's adjustable, but I would think perhaps Hogstrite would allow you to demo that in the office. But I think if I'm correct, it's in the vicinity of $3,000 for that set of oculars. So it's not inexpensive. Um, uh, but reducing the size of the table and just making certain that you try and bring the patient closer. But yeah, anything that extends the oculars so that you're not reaching as far as is obviously beneficial.
I've had a chance to use the inclined oculars. I think specifically for me, because I'm shorter stature and I have a shorter torso, it was very hard because it sort of increased the height distance for my torso, and our stools don't go high enough for me to be able to adjust to that. So I think for those that have longer torsos or just taller, it would be a great thing. But for someone like myself, it didn't really work that well. But it was something that one of my colleagues had alluded to, and we sort of asked Hogstrite to bring in for a trial. And I think they are doing some opportunities where perhaps at our academy meetings to incorporate that ergonomic piece. One thing I did want to say is I'm not sure about you guys, but when I look at their websites, there's not like an information section for how to improve your ergonomics or what kind of tools. It's sort of hidden what available oculars, what available adjustable teaching scopes are there. And even the concept of the microscope distance, right? So in terms of there are actually different focal distances that you could set for your Zeiss or Leica But that's not really readily available on their website. So unless you specifically ask for or talking with the rep about, is there a different working distance so I can decrease the height or how close it gets to the patient for focus, they're not going to bring it to your attention. And I think switching out that focal distance can make a big difference if you're sort of stretching or reaching or having a harder time.
That's great. I think there's some really important points there. One thing that Amy, you and I have talked about is that because we're all different builds, two people who are the same height can have a different ratio of their torso to the bottom half. And what works for one person then is not going to work for another person. So you'll hear things like, oh, I really didn't like that chair that someone else was using, or the angled microscope, that thing's terrible, but somebody else finds it really helpful for them. So we're all kind of on our own little ergonomic journey. And as Dr. Masket, you were saying, the most important thing is raising awareness, is for you to learn what works for you and understand when your body is talking to you and saying, I don't like this. When you're feeling that little pain in your neck, you need to take that micro break and change things. Another question here in the Q&A is, what do you do to help when you have to manually refract a pediatric patient with individual lenses? I see some head shaking.
I think the most important thing to do there is to raise the chair height of the patient so that you're not reaching down. And so you may have to have that child up pretty high so that you're not hunching over to do it. So you have to raise the child. And yes, you have to keep reaching for lenses, but and it's a little bit, stressful on the arm, but not so bad. But the point is to have it at your eye level, to have the patient's eye level at your eye level in your position of comfort, so that you're not slouching over or what have you.
That's great. Another question in our Q&A, when it comes to neck positioning at the slit lamp or at the OR microscope, is it better to have the neck slightly extended or slightly flexed to limit the risk of stenosis? And we saw a good example from an MRI earlier. They mentioned. Maybe I'll throw that to Randy first. Do you have any comments about that, Randy?
So for me, it's trying to get that neck into the neutral position. There's literature and I'm going to take it from office ergonomics, that if I put my head into an extended position, there can be problems. And if I put it into a flex position, there can also be problems. And the flex position is a lot, you'll know better than I, but our vestibular system wants to keep our eyes horizontal. So doing this, trying to look forward. So we end up adopting this kind of a head forward posture with trying to flex. So neutral.
But, and I'm not an expert other than having a problem, but to me, if I had to choose between slight flexion and slight extension, it would be flexion. And the reason is that with extension, you get that hyperlordotic curve. And the more you do it, the more you want to do it. And I think that's where you're really, really putting terrible, terrible problems on your neck. So I think overextending the neck is really problematic. That's my view.
Dr. Zhang, any comments?
I was just going to say, depending on which one you tend to overdo, sort of having that micro reset to do an opposite action, maybe another way to counter that. I think, one thing I was told that, you should imagine that there's a string and it's pulling you up straight. So that's sort of what neutral is. But I think for so many of us, where we have our natural position, that we don't even know what neutral means. So without having that visual of what you actually look like, it's really hard to just tell someone, just do your neutral position. Because for us, because maybe we're so ingrained in unneutral positions, that it's really hard to understand what that means, at least for me. And being that we're ophthalmologists, we're really visual, I think that picture really sort of highlights what kind of tweaks or adjustments may be helpful.
Yeah, that's great. One thing I always talk about is just completely relaxing your body. And often what I find when I do that is my eyes are no longer in the oculars because I've shifted a little bit, because maybe the patient's head has turned a little bit and I've moved my XY, or maybe I've moved from where, for example, I'm doing my VIT and then I've gone to my peel, and so my microscope has changed in heights. And I might be operating kind of like this, and every now and again I say to myself, relax. And when I relax, I realize I'm not in the oculars anymore. So I have to move my chair down, or unlock and shift my chair this way or that way. And again, that goes back to that micro break. Every 20 minutes, resetting, just relaxing, and getting yourself back into a good position. We have a lot more questions in the chat, but unfortunately, our time together has come to an end. I'd like to once again give a sincere thanks to our invited speakers, to Dr. Zhang, to Dr. Masket. Appreciate, Randy, you giving your insights as well. Thank you to all the attendees for joining us tonight. We really, really appreciate it. We are hoping to raise awareness and to continue on doing events like this. We really need you to be here live and contributing, and it's been a really great night that way. Thank you to the Scientific Planning Committee for their invaluable input, and a huge, huge thanks to the COS team. It is such a pleasure working with you. You're amazing. I really have enjoyed this whole process with you. A reminder that this session is accredited by the Royal College. Please don't forget to complete your evaluation forms and to claim your credits. And with that, I will say good night. Thank you very much.
Night all.